I think we could continue to talk about polycythemia vera for quite some time, which is really different than 10 years ago, isn't it? Or maybe 20 years ago, even before the JAK2 variant was found in PV. But it's time to move on, and I'm going to ask Jamil to start with a discussion of patient classification and risk stratification in myelofibrosis. And for the sake of time, we will not spend a lot of time on the diagnostic criteria, which are well published by the WHO, and just move on to risk stratification and then how that affects management of patients. Jamil?
So there are multiple prognostic scoring schema that have been developed over the years. The very first one was published in 2009 by Cervantes, and it's called the IPSS, which was a tool that was utilized at the time of diagnosis to risk stratify patients relative to their survival. And there were 5 variables that were utilized: age over 65, white cell count over 25,000, peripheral blast count over 1%, presence of constitutional symptom, and hemoglobin below 10. So that kind of gave you 4 various risk groups with median overall survival ranging from 130 some months down to 27 months. So you can see tremendous variation of variability. And in general, people think low to INT1 is lumped together as one entity, and then intermediate 2 and high risk disease as another. Mostly stem cell transplantation was offered to intermediate 2 and high risk disease, but then it became clear that as people went on to live with this disorder, that they acquired other features that may also correlate with worse outcome, namely a development of anemia or transfusion dependence. And this is why the dynamic international prognostic scoring system was created to account for the development of anemia in patients who may not have been at the outset. And so that was the next advance, if you will. And then later on, the IPSS Plus also accounted for a few other variables. So including in that platelet count below 100,000, the presence of adverse cytogenetic abnormalities, and the development of transfusion dependency. The bottom line is that whichever score you utilize, remember that IPSS is good for the time of diagnosis, and the dynamic scores are good throughout the disease course. When the mutations became available, with JAK2, MPL, and CALR, and people started to look at the impact of those mutations on the outcome of patients who have myelofibrosis, then obviously there was a trend to think perhaps to include those mutations into the scoring schema. So there's something called mutation-enhanced prognostic scoring system that encompasses the presence of certain mutations that are labeled as high risk. And then that kind of evolved into the MIPS 70 plus, which includes cytogenetic abnormalities, and all that culminated in the called a genetically enhanced prognostic scoring system, and that does include both molecular and cytogenetic abnormalities. So these are, I know this is a lot of information, and obviously all the little bullets that you have in there to construct the scoring schema is very interesting, and it may help again in selecting people who may be candidates for stem cell transplantation. So that I will stop here.
Thanks, Jamil. Well, that was an excellent summary, because it has evolved and has now included the mutational and cytogenetic data, which is prognostically very important.